One day I was fine, and the next day I wasn't. And after a couple of weeks of being treated for pneumonia, I ended up in the emergency room right before Christmas. And to my surprise, I was diagnosed with not pneumonia, but stage 4 non-small cell lung cancer. During each of the sessions, I had a reaction. So I was nervous before I started this treatment. But the care that you get from the nursing team there is, they're always just so phenomenal.
Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer.
Hey everyone, welcome to Cracking Cancer. I'm your host, Dr. Kyle Concannon, and joining me today is Jeanne Zurek and Rob Swanda. And today we're talking about different routes of administration of medicines. And I'll let you both introduce yourself here. We'll start with Jeanne.
Hi, I'm Jeanne Zurek. I'm a stage 4 EGFR cancer patient, and I live in Minnesota.
And that's a type of lung cancer for those who are not familiar with the mutations we have.
Hey everyone, I'm Rob, science communicator here, trying to help people understand the complexities of science and make them more excited about learning about what's going on and advancements in medicine.
Well, thanks to you both for joining us. And Rob, you also have a particular expertise in the biology and science behind these different routes of administration, which I'm super excited to get into because I think you have a lot to teach me here. Despite me being the one that prescribes these medicines, we don't always know the deep nitty gritty of how they work. So excited for me to learn something here. But kicking it off with Jeanne, you had this history of this stage 4 lung cancer. You've been on multiple different treatments and have had the same treatment with different routes of administration. So I'm wondering if you could give us some insight into your clinical history, like what led you to have these medicines.
Yeah, in December of 2024, one day I was fine, and the next day I wasn't. And after a couple of weeks of being treated for pneumonia, I ended up in the emergency room right before Christmas. And to my surprise, I was diagnosed with not pneumonia, but stage 4 non-small cell lung cancer. And we weren't sure at first that it was lung cancer because I had had cancer 4 years earlier. So we did the biomarker testing right away, which is very important. And we found that I did indeed have lung cancer and that it was with an EGFR exon 19 mutation. So I started on osimertinib, and I was on that for 5 months. And then it kind of stopped working for some reason. We did another biopsy, a bronchoscopy this time, and found that I had an atypical mutation. And my doctor suggested trying amivantamab as the next therapy for me. And so I started with the amivantamab IV intravenous in July of last year. So I've been on amivantamab since July of 2025.
And for those here who may not be in the lung cancer sphere, what is amivantamab generally? How is it different from the medicine you were on beforehand?
Osimertinib is a third generation TKI, which inhibits the EGFR. And the amivantamab is what's called a bispecific, and it is a monoclonal antibody. And it sends a very large cell onto the cancer cell to kill it, basically. And the advantage of it being a bispecific is that it also targets MET. And they're finding that it also targets other mutations. And that is what has really been the key to my treatment, is that it's getting these other mutations as well.
So it sounds like you went from a medicine that was a pill, really. These TKIs, for those who may not know, are oral. And we usually just give them, daily, some are more than once a day, but they're pills you take. And then you transitioned over to a different type of therapy because the pill type wasn't working. So they transitioned to something that needs to be infused into the body some way or another because we can't swallow antibodies. Our stomach would dissolve them. So they have to be injected. They have to be sent in, bypassing the GI tract. And maybe this is a good time to pivot to Rob. Rob, can you speak to the different types of routes of administration that one might experience when receiving cancer therapy?
Absolutely. So, as Jeanne mentioned, a standard form of delivering medications is through an oral or a tablet form. Another way that one may receive medications is through an IV, which Jeanne also talked about. And typically this is going to be for a biologic. So as Jeanne mentioned, amivantamab is a monoclonal antibody. So as we see more and more of these type of monoclonal antibodies hitting the market, a lot of times they are going to start in an IV formulation. And that's also another way that some chemotherapies are also delivered. But then there's another form of delivery of these drugs that can be known as subcutaneous injections, or SC injections, as you may see it abbreviated. And that's where the formulation is actually given just directly under the skin, and it's given via a syringe push. There's a couple other devices that could be used, such as like a wearable device or help with a pump. But for the most time, it's going to be a healthcare worker manually injecting that medication under the skin for an individual to receive that medication in a shorter period of time. So if you think of an IV, you may think of generally individuals sitting in an infusion chair. It can last 30 minutes, an hour, 2 hours, sometimes even more. And when we think about subcutaneous injections, those are typically going to be in the range of anywhere from 3 to 10 minutes, depending on the volume of drug that's being injected.
Jeanne, when you were receiving the intravenous form of amivantamab, what was that process like?
The first week, amivantamab has to be delivered in 2 doses, one the day after the first. And it can't be delivered by port either because of the proximity to the heart. And so I had to have it delivered through the vein, even though I do have a port. So after the first 2 days, if everything goes okay, you come back and you do it again for the next 4 weeks in a row. And during each of the sessions, I had a reaction right from session number 1. Luckily, most of them were near the end of the session. So in the first case, we were able to finish because I only had about 5 minutes left. The second day, we just stopped. I had 10 minutes left. And my doctor just said, I think your body is saying that's it. And so we stopped right there. And it went along like that pretty much every week for those first 4 weeks. After about week 3, I think I didn't really have the type of a reaction that required more than just, a couple minutes stop. And then we finished. But by the 5th week, that very last week, we decided to reduce the dose. So we reduced the dose and then built it back up during August again, when I was going every 2 weeks. And then I was still having bad reactions and side effects, mostly the side effects after that. And so it led to another dose reduction that I was actually on a dose reduction from September until January.
And when you say an infusion reaction, I think when a lot of people are thinking about cancer treatment and they have this feeling that a foreign substance is going into their veins, the concept of a reaction there or something that happens right as that drug hits the body is really scary to people. I mean, it's scary to us in the healthcare field too. But I think anyone receiving something new, and a lot of these things are really medical stuff. This is stuff we make in the lab. Can you speak a little bit to what the infusion reaction you experienced was?
Sure. The first time, it was just I started feeling flush. And so I rang the bell, and here comes the crash cart. And the nurses took care of me, monitored my vitals and everything, and checked with the doctor. And then the second time, it was a sudden shortness of breath. And we stopped then. And so it was things like this. Or one time I got, I think the start of hives, just a line going up my arm. And so we stopped and treated that with some more Benadryl, and then I was okay. So they were reactions like that. I never had any serious reactions to this, to this treatment. Not what I would call a serious reaction anyway.
Sure. And when you were experiencing these reactions, what was your feeling at the time? Like, were you afraid that things were going to progress? Did you feel reassured by the medical team? What were you going through?
Yeah. So I had had cancer before, and I'd been through chemotherapy, and I had much worse reactions the first time. So I was nervous before I started this treatment. But the care that you get from the nursing team there is, they're always just so phenomenal. That they're keeping an eye on you whether you know it or not, and they're right there. They were there almost before I could ring the bell, it seemed. And they take good care, and they reassure you that everything's fine, and they've already contacted your doctor before they're even over at your chair. So I never, with these reactions, I never got panicky about them or anything.
Yeah, I love hearing that. Not that you had the reaction, but that you had such confidence in the care team, because that's my experience on the provider end. A lot of times the nurses this is what they do. They see this
Yes.
all the time. They have the clear what to do when in reaction to what. So the things that the individual is experiencing, it's often their first time experiencing one of these reactions, but the nurses deal with these every day. So I'm happy that you felt reassured appropriately, and very, very rare that one of these infusion reactions ends up being something critical, because our protocols are so ironed out. They're so good at this point.
And that's a benefit of the IV route of administration, is that you can pause, you can take a stop, you can address any adverse reactions that are happening. And if it's determined to allow that patient to continue, then the infusion can continue. Or if it needs to be stopped, they can stop giving that individual the drug. So I know we're going to talk a little bit about how this route of administration has changed for you, Jeanne, but I think I just want the audience members to understand that I don't think that the IV route of administration is going anywhere, and it is very common practice, at least from what I've experienced and what I've learned in the clinic, that one would start with these IV infusions to make sure that the patient is familiar with make sure their bodies are familiar with the medication and are not having adverse reactions. If there is a subcutaneous formulation approved of the same drug, the patient wouldn't just immediately start out on it. That's what I've seen in the field, at least.
Yeah, I think that's my practice too, is a lot of times if we have the option between something that would go intravenous, through an IV drip, or we do an injection, which is, once you put it in there, you can't take it out. So if you want to make sure that a certain medicine is good for someone's body, a lot of times they'll start with that IV, because you can always turn it off. If they're having a big reaction, just something weird's going on, or even you just want to develop comfort with the patient on a new medicine and know that they're in control, that, look, if you don't feel good at any point, we clamp this, and and we stop. Whereas once it's in there, I worry about the anxiety of not being able to turn back. So a lot of times I will start IV and then we'll transition to SubQ once someone's comfortable. And Jeanne, that's what you did at some point. You had IV amivantamab and then you transitioned to the subcutaneous form, the injectable form. Tell us a little bit about what guided that decision.
Convenience. I think when I started on amivantamab in July, my doctor clued me in that approval of a SubQ treatment was on the horizon and that it was expected any day, which turned out to be 6 months later. And that intrigued me. So I started looking up, about it. And I was looking forward to it from the day that I started on the intravenous, actually, because he said it's going to be available and you won't believe how easy it is, because they use subcutaneous injections for other drugs, other cancer drugs. And he said, you're such a busy person. You're going to love this. So, I do.
Yeah. And how is your experience different? Like, what was the experience of going into the infusion center, getting the infusion, and how does that compare to your experience now going and getting the injectable form?
Yeah. So when you go in for an infusion, first, of course, you have the blood draws and then the doctor appointment. And then when the doctor says it's a go, you head down to the infusion room. And normally they start with the pre-medications, the steroids and the anti-nausea and everything. And so then you have about a half hour you have to wait. Then they start with the infusion. And for me, those infusions would take anywhere from 3 to 7 hours. Was the longest. And then we got it down to about 5 hours when it was on the full dosage of the amivantamab intravenous.
Well, and for those listening, I just want to quickly add that duration of time is probably because you had those reactions. Not everyone getting infusions their first time is looking at a 7-hour day, but you might, if you have these reactions.
Right. Yes. They told me that usually it would be about 2 to 3 hours for the dose. And I did in the last few months, but of course I was still on a reduced dose, and it was taking about 3 hours. So
then after the 3 hours, you were, they cut you loose.
Yes.
Did you feel okay after the infusion usually?
Yes, for several hours. And then one of my reactions, early side effects, was body aching. It would start in my hips and go all the way down my feet. So I just would have these body aches and maybe a little bit of chills on the first or second day of it. And then after that, I was usually okay. Just dealing with the other side effects.
Sure. And how did that differ from the injectable form when you transitioned to that?
Well, when I got my first injection, it took 5 minutes. And I was actually sitting there giving my information to a woman from the university who was signing me up for some kind of study. And she wasn't done signing me up, but the nurse was done with the injection. And I was shocked. Actually, I just found it so amazing that I said, all of that in 5 minutes? I really couldn't believe it. And I had no reaction. Absolutely no reaction. I didn't even get those body aches later on or anything. And I know that part of it was that I still was kind of under the influence of the steroid, but I went out and I raked the lawn. I raked leaves that afternoon, and it just, enjoyed the day. So it was a lot different, because when I came home from an infusion day, I was pretty exhausted. I was pretty tired. You wouldn't think so, just sitting there in the chair, for hours, but it really does get exhausting.
And how did the pre-meds change, or did they?
They did, because now with the infusion, I would have to take the dexamethasone steroid starting 2 days before infusion, and leading all the way to 1 day after the infusion. And then I didn't sleep for days, and then I would just crash. And so it wasn't very pleasant. But with the subcutaneous injection, I only needed the steroid before the first dose. And then when I didn't have any problem after that, I didn't have to use the dexamethasone anymore. So that has been the biggest benefit. Plus, I can take my Tylenol and Benadryl and the other things to prep before I go in to the clinic. And so I can just go in, see the doctor and everything, and sit down and get the injection without a big, hour-long delay. So the only delay is in the preparation time of the solution.
Which sounds like doesn't take all that long.
No, I maybe sit there for a half hour, if that. So it's been great, and because I had no reaction after the first dose, I don't have to stay to be watched either, and I have not had a problem. I know other people do. I've heard, this is my experience, but I have not had a problem with it, and it's been really an amazing change, in my thoughts anyway.
Yeah, and Jeannie, just to give you a little snapshot of what's going on while you're waiting for your syringe to show up with the solution inside, is that typically what the nurse has done is they've put in the order for your drug, and then the pharmacy on site is preparing that drug, and they're already having that volume in a syringe ready to go. The nurse will go and pick up and then bring to you for your injection. And then you're saving all that time, because even though they're doing the same thing for something that would be given IV in an IV bag, the nurse would also go and pick up. You lose all that prep time in terms of, you don't have to flush the lines. You don't have to check the port if you are going to use your port. As you mentioned, you're not getting as many of the pre-meds. And I saw that too when I was visiting infusion clinics, is that majority of the individuals who were getting subcutaneous injections were not receiving any pre-meds. So again, speeding up that time. And then typically they asked them to wait around for 5 minutes afterwards. This was typically for individuals who were like maybe new on the medication. I don't think it was a hard, you have to wait 5 minutes. It's just, we would like you to wait. And then, but if there was individuals who were coming in and they were seeing them time after time for their injection, and they knew like, I've got this, I don't have reactions, typically they would just get up and go. So everything you described with what you're doing and with your subcutaneous injections is exactly what I've seen in the clinic as well when I've done observational studies.
Yeah, and Jeannie, I'm interested to hear the experience you had with the injectable form. Speak to maybe how much time the transition over there has changed. How frequently were you getting infusions, and is it the same frequency that you get injections? How much value does this add to your life in some way?
Yeah, that has made a difference too, because with the amivantamab infusions, I was going in every 2 weeks, and then when I switched over to the SubQ form, I started by going in every 2 weeks to make sure. So I got the lower dose every 2 weeks for the first 3 weeks, first 3 times, just to make sure that I was tolerating it and we were controlling side effects and things. And then when that all worked, then I switched over to monthly. So I go in every 4 weeks now, and so half the amount of time. And that's made a big difference because it really opened up my schedule by, adding another day in there. And the only downside is that, I really like my doctor and I really like the nurses. And so I kind of miss them, but I know that I'll be seeing them forever. So there is that always.
Well, and you raised such a good point with that. We are starting to more and more consider this concept of time toxicity. We think of all these other ways where the treatments we give cause morbidity, not necessarily mortality, but we really want to emphasize morbidity too, which is to say, how are the ways that this experience is detrimental to your life compared to what your life was before? And so many people are really, their lives have to revolve around their infusion schedule. And particularly for individuals who have infusions that have side effects, if your infusions are really close together and then you have side effects in between and then you recover, you get another one, there's just so little one can do. So when we're looking at changes to how we're administering the things we have, how do we optimize what we're doing, get the most juice out of the squeeze that we have, and get better survival benefits in a more lived sense way? Like, how can you enjoy your life better with what we have? We really, really hold on to those. And this whole realm of opening up to IV and then other thing, or IV to SubQ, and then the things that were one of those often to pill, we are really excited about those options. With the whole idea of, as an oncologist, I want you to see me the least amount you need to. That usually means things are going well and you're doing better things with your life. I'm particularly thrilled that your time went from hours and hours and hours, and with the added toxicity of the reactions you were having, to 5 minutes in and out, probably with some clearance from the doctor, of course.
Right. I know that some doctors, some clinics require you to stay longer, but not for me. But the thing that really helps me too is that when I was at ASCO, and I got a chance to talk to the doctors and the researchers there at the poster sessions. I did ask one of the doctors who is studying the amivantamab SubQ about the efficacy of the 4-week. I said, is the 4-week as effective as the 2-week? And if so, what are you seeing as lasting effect, lasting efficacy? And she told me that it is exceeding the 4 weeks. And I probably shouldn't say how much by, but I'm really encouraged that I may be able to avoid getting an injection if I want to go somewhere warm during the winter for a few weeks.
You mean with the amount of time that the antibodies stay around?
Yes.
Yeah.
Yes.
That's another element that we get so intrigued by as people get really tied to the not missing a cycle. But with some of these antibodies, it's actually pretty safe to do that, depending on the type.
I was doing well enough in the on the IV earlier in the year that after my December scans, my doctor said it was okay for me when I had to skip one cycle.
Yeah.
And, and I still came up, no evidence of disease on the next scan. So it worked.
I love it.
And following that same space, like in a dream world for the drug delivery space, is that there are talks and there are hypotheses and there are investigations going on to see if this could be given in a home setting, or is there ways that individuals could receive these subcutaneous drugs either through a device, so maybe that's something like they would self-inject, or they would have a caretaker self-inject, or maybe someone would come to the home and inject them. But there are things out there that are currently being investigated to see if this would even be a possibility, because it adds into everything you and Kyle were just talking about, Jeannie, to allow individuals who are patients to get more freedom in their lives and not have to constantly be going back to these infusion clinics on a monthly basis, or even on a bi-monthly, whatever it may be.
Rob, speaking to your expertise around the pharmaceutical element of these injectables and how they differ from IV, like what's biologically going on in these things? How can we inject these and they be slowly released? What's happening?
I would say that there's been a lot of advancements that have been happening in the delivery of subcutaneous drugs. So if you think of a typical subcutaneous drug, maybe like a vaccine, that's a very small amount. Think of it like a half ml to 1 ml if you're just picturing it in your head. And it's quick, right? It's given in about 10 to 15 seconds when you're at a pharmacy or at a doctor's office. And we always thought in the drug delivery space, well, what is that threshold? How high can you actually go under the skin when you're delivering some type of therapeutic? So studies were coming out about, oh, well, you can go up to 2 ml, and you can go up to 3 ml. And then slowly that number kept getting bigger. But what was a constraint was individuals' pain tolerance in getting that drug, because it does need to go somewhere so it can expand the skin. And Jeannie, I'm not sure if you've ever experienced this with any of your injections, but sometimes you can get a little bolus. So like the skin kind of bubbles up a little bit, and it can be a little firm for a small period of time, and it can be painful for some individuals. And so that was something that was always thought about. Well, how can we reduce that bolus formation, or at least have it diffuse out more quickly? And one big advancement that happened in the pharmaceutical space over the past 5 to 10 years was a specific molecule called hyaluronidase. And that molecule helps to break apart a specific protein within our skin. And that protein is known as hyaluron. And that's what helps the drug actually get to the bloodstream. So the way that I like to think about hyaluronidase is that, say you're trying to get all this material through like a chain link fence. It can go through there. It might go through there at a slower rate because it's hitting some of those chains as it's trying to go through. But hyaluronidase comes through, and it's almost like you're clipping all those chain link fences, so then it can just wide open, and it's like the floodgates open, right? It lets all that drug go through all at once. But what's really cool about that protein is that it actually rebuilds itself. So the hyaluron in your skin doesn't just go away after it's treated with this drug. It will repair itself within about 48 to 72 hours. So then your skin still has that barrier of protection underneath it. So that's what's really helpful in getting a larger volume of drug, something that amivantamab is probably in the 10 ml to 15 ml range, into this under the skin and then into the bloodstream. So what we're really trying to do is get it to the bloodstream. So then, as Jeannie mentioned earlier on, this is a bispecific antibody. It needs to get to its destination, and it's going to use the blood in order to find those cells that it wants to attach to.
And one follow-up question there, I think it's a beautiful explanation. Why does the administration subcutaneously lower the reactions? Like, what's happening through the vein that isn't happening subcutaneously?
Yeah, I think that's a great question. And to be honest, I really don't know the full answer of why there would be less reactions going on. Part of me thinks is that because you're going into the skin and then just going directly into the bloodstream, is that you're avoiding this systemic effect where it's circulating the body. You're having it there for a longer amount of time because it is a much larger volume of formulation that you're having given via IV. Now, that doesn't mean a larger concentration of the drug, just a larger formulation, right? So that's diluted into a solution in order to then be given via IV, and then it's going to be circulating the body more. So then maybe there's more chance for it to have an adverse reaction, bind to things that it's not supposed to. That's just a hypothesis. I'm not sure. But with the subcutaneous injections, they are seeing that it is having less of those side effects for individuals, and they're able to not have to stop their treatments or deal with any of these adverse events.
Yeah, I love your explanation there. And I, when we have an adverse event or we have one of these infusion reactions that Jeanne, you were feeling, a lot of times we'll pause, we'll give some medicines, we'll get people feeling better, then we'll really lower the rate. And I think there's an element of that rate that probably matters. So the way I think about it, and I would love if someone's listening and you know more about this than I do, let us know. When you inject something into the skin, that hyaluronidase needs to work, the diffusion from the area under the skin into a bloodstream, which then delivers it to where it needs to go. Getting up to your maximal dose that it's going to get to is probably happening over quite a long time. You're just not sitting in the chair for it. And, Jeanne, I'm interested to hear more of your perspective here. At the longest rate that you were getting these infusions, like the longest amount of time that you were sitting in the chair, how did those reactions compare to when you were in the chair for shorter? Did you have fewer infusion reaction or did you have more infusion reaction when you were in the chair for longer?
With the IV,
With the IV.
I don't really think it made a difference. I usually had the reactions toward the end of each dose. So I think there was only the one time when I kind of had the hives that was earlier. So the rest of them waited, the reactions waited until I was almost through each day.
Was that
But
regardless of how long it was? So even if you were in the chair for the 7 hours, you were still getting reactions at the end, or?
they were fewer. Once I got through the weeklies, when I was on every 2 weeks, and those were reduced doses at a reduced rate also, then then I really didn't have reactions to those. And we titrated up, so we increased the rate every time I came in to see how I would do, to shorten the administration time, and that all worked okay.
Okay. No, I'm happy to hear that. And, it's interesting that we do have this sense that the subcutaneous forms tend to not have those same infusion reactions. I mean, they're called infusion reactions usually because they're specific to the infusions. So I'm curious what side effects stayed the same when you transitioned over from the IV to the SubQ.
Yes, the side effects, I still have the skin and scalp rash that I deal with. That comes and goes. It's kind of like a little river flowing there. And I still have edema. I still have neuropathy. But overall, the side effects are much milder, and they're much easier for me to mitigate. And I have not had the things like that I had before, like the chills and the bone aches that I had with the intravenous. So several of those symptoms are gone, and so everything seems to be going pretty well with this.
Yeah, it's interesting because I think a lot of the times we think about it as really the only difference between IV and SubQ is those infusion reactions. We think of the long-term side effects usually being pretty similar between the two, but there's person-to-person variation. Everybody's body experiences things differently. So
Yeah.
I like hearing your perspective here because I think, one, it kind of bucks a little bit of our the trend we tend to discuss. And I like having, an N of 1 is still someone's experience, meaning if we don't have a big population of people mentioning a certain change. If it's just a few people, well, that's still real. It doesn't have to be. We don't have to do big trials all the time to identify some benefit. And I think that's one of the big benefits of the patient advocacy organizations. So for those listening, there's many different patient advocacy organizations. These are groups of individuals who have a shared type of cancer or some shared experience, usually around cancer, in one way or another, and they can talk about their day-to-day experiences and the things that they've experienced, negative or positive. And we are increasingly gaining insight from that. And a lot of these kinds of things are things we're not going to see from trials. We won't necessarily see, did someone's side effect that they were getting from the IV get better when they went to SubQ? We might see what are the rates of a side effect in the IV setting and what are the rates of the side effect in the SubQ setting. We're probably not going to see what happened to the same person. But you will probably get that when you're meeting with a patient advocacy organization. And this wasn't the direction I was intending for this discussion to go, but is there a patient advocacy organization that you particularly work with, Jeannie? And if so, who might that be and how do people contact them?
Yes, there is. I volunteer as a lifeline buddy mentoring lung cancer patients with the Longevity organization and also with Go2 for lung cancer. And both of those organizations provide so much information and so much support among other organizations. But those in particular have been so helpful to me, so vital to me. And so I'm happy that I can give back by helping other lung cancer patients who are going through what I'm going through. And together we share information, we share our experiences, and we support each other. And then it also helps us to keep informed about everything that's going on in the lung cancer area, which is just absolutely fascinating and fast moving right now.
Yeah, and a lot of the experts in these patient advocacy organizations are people that I reach out to when I have questions, because depending on how nuanced they get, and they can be very nuanced, that the people in that organization may know updates about things before I do. So if I'm in a bind, I'll rely on, what did someone else come up with? Because patients nowadays, with the advent of the internet and outsourcing a lot of these questions or crowdsourcing a lot of these questions, people are really knowledgeable. Most patients with a rare cancer diagnosis, if they dive into the treatments and the community around that, they'll know more about their diagnosis than most oncologists will. I stand by that. So it's a really good resource for a lot of individuals. So I always try to plug whichever ones are applicable whenever I can. I've gained a lot from them.
It has been so vital for me that I actually was able to get some ideas about mitigating a couple of my side effects and take them to my doctor. And he said, yeah, let's give this a try then. And, I shouldn't say it, but a couple of weeks ago when I was in for my treatment, I suggested that he put me back on doxycycline for a couple of weeks to try helping my skin rash. And he says, why not? You're smarter than me.
Yeah.
And so to which I said, no, absolutely not. You're the doctor. So,
I mean, you say that, but in reality, the group experience from these organizations, that organization has the experience of more patients on, say, amivantamab than any given oncologist probably does. So in a sense, if you're able to pull that and utilize that, you can get big numbers, really good shared experience. And I always encourage people to bring that information to their doctor, including around if there is the chance to change from one form of giving a medicine to another. That's a really good topic to bring to a patient advocacy organization that may be relevant to you, and just pull folks, did this help you? What were the pros? What were the cons? And I'd love to hear a little bit about how that changed your life, Jeannie. You know, what are the things you couldn't do before that you can do now that you've changed from IV to SubQ?
Well, now that I'm on SubQ, I have more time to go and, do things after I finish, because like I'm done with my infusion or my injection, by say 11 a.m. And I have all the rest of the day to get out. I like to volunteer. And so that just opened up one more day that I'm available to volunteer, along with that. But I think that's probably the biggest difference that it's made, and then also the flexibility where I was planning on going on a trip in August, and I looked at the schedule and I saw, I'm due for an injection that day. So when I went in this month, I just asked the doctor, "Can we just delay it another week?" And he said, "Yeah, sure, no problem." So I'll go in the next week, and I don't have to take a break from during my vacation to get an injection. So that's really nice. And I know also that this has helped me feel better faster. I don't have that crash that I would still be having, from the steroids and the IV. Basically it would take me out, for like 3-4 days. I don't have that now. I still deal with some fatigue, but that's cancer.
Yeah, I love your phrasing here. And for those who haven't received cancer-directed treatment, we use a lot of steroids. There's a lot of steroids in a lot of what we do, and steroids can definitely make people stay awake. I've had to have hydrosteroids for things, and it wasn't until I received it myself that I was like, "Oh, this is what I've been doing to people." And then I didn't fall asleep until 4 a.m. It was just like it's 2 a.m. and I feel like it could be 2 p.m. It's just no way I'm going to bed. And then you do that several days in a row. Yeah, I can see those things that this is a pre-med. This is something that we give to make people feel better and to prevent side effects. But that in itself has so much of a deviation from your normal life. And how frustrating is it when you have plans in the daytime and, you look at the clock, it's 5 a.m., you haven't slept yet, and you're supposed to be somewhere in 3 hours. So these are huge deviations from someone's life. And the different way we formulate our medicines can change that experience so much.
And I'm really happy that you mentioned all that, Jeannie, about how it's impacted your life, because a lot of what I saw when I was in the drug formulation and delivery spaces was how does it impact the healthcare workers' lives who are actually administering the drugs, right? And how does it affect the ecosystem at an infusion clinic on patient turnover? And I always felt like they weren't necessarily thinking of the patient as much. It was always looking at the healthcare workers and how quickly they could administer drugs to more patients, so helping more people throughout the day and getting them through at a faster rate in order to make sure that they're getting their medications on time, or if they need to move people around, it can be a little bit more flexible. But just hearing your story and just what you can do in a single day, I really hope that some of my friends who are still in the drug delivery space are listening, because I think that's a huge thing that needs to be considered for these different places who are formulating new devices or new technologies, new formulations, in order to make sure individuals who are getting the treatment are getting them in a timely manner.
I love that you mentioned that, Rob. I was nervous to bring that up. I didn't want to come off sounding like I'm like sitting here saying, "Oh, they're really great for the healthcare administration."
No, it's true. That's really what is consistent that you hear at a lot of these drug delivery conferences and drug delivery meetings is the time saving for the healthcare workers, which is absolutely true. And that's also why when I talked earlier, Jeannie, about how potentially this could go at home. I mean, this is headed in that direction. And I don't know if you've seen the article, and Kyle, I can send it to you afterwards, but there's actually a new wearable device that was just approved. I think it was last week or within the last 2 weeks for an oncology treatment. So it's a device that somebody would actually wear, and it would give them their drug in a subcutaneous formulation without somebody having to stand there and push the syringe, right? So I don't know if that's delivered at only a healthcare facility or if it's delivered also in the home care setting. But things are moving, and thinking about the patient is so important. But both people, I think, on ends save so much time.
Well, and the time saved in the infusion center, what that actually equates to and why we think about that in a really strong way is if someone comes to me with a new diagnosis of cancer and they need to get on treatment now, like they have a lot of disease maybe in their liver, or they have things in the brain, they have things we really don't want to sit on, I have to wait until the infusion slot is open. So that can be 2 weeks, that can be 3 weeks. So that duration of time that someone who is already on treatment, like Jeannie, if you have an infusion reaction and your next one is 7 hours, we're not going to kick you out because someone comes in with a new diagnosis. You have that infusion slot. And for you to be able to have a different way to administer the same medicine may mean that 3 other people can now get treatment that they couldn't otherwise get in a fashion that's more timely. So that's usually where the healthcare field is coming in, or administration is coming in, is how can we decrease delays in treatment, which anyone who has been diagnosed with a metastatic cancer or even a localized cancer, that time to treatment, I can't emphasize how scary that time interval is. And we share that fear a lot of the time, that we do not want to wait on this. And these kinds of technologic adaptations and iterations on what we've already discovered, if you can get 2 times the number of people or 3 times the number of people infusions, or just their medicine, however you're going to get it, that is a huge, huge win for the cancer community. We're not quite at the level of blow darts, but once we get to the level of the blow dart formulation, I'll be all for it.
It's so important for what you were saying too, Kyle, in terms of like Jeannie as a great example, because your drug is in a subcutaneous formulation. That's not the case for all drugs, actually, for a majority of drugs, right, that people are receiving. So if you're listening in on this call, and I completely agree with what Kyle was saying, is like advocate for, if you want to talk to your healthcare worker about, is this available in a SubQ, and see if it is available. But for a lot of drugs, it's still in that transition phase. They're still trying to see, is this possible for those biologics? And it's very specific for biological drugs. So Jeannie's getting a monoclonal antibody. Things like chemotherapy, as far as I know, I have not seen any studies on, is not being given in a subcutaneous injection. That is going to stay in IV. So if you're getting chemotherapy, that does open up those slots for the longer sitting in the chair receiving your IV infusion, versus if you have that option to receive a biologic in an injection form, that can speed up that process for those specific patients. So there's still a long ways to come in order to make sure that it hits all different patients in different cancer types. But I think that there's still a lot of progress that has happened over just the last few years in seeing a large number of drugs in the biologic space being approved for SubQ, or at least getting close to approval in SubQ.
I couldn't agree more. It's such a huge advancement, Rob. And one question I have that's kind of a big picture question, Jeannie, do you think, and interpret this however you want, do you think it's better to have the SubQ formulation lifestyle or the daily pill lifestyle? Because in the SubQ, you still don't have anything in between. Whereas in a daily pill, you do have this daily reminder, you have this daily thing you've got to do. I'm just curious your thoughts there.
Well, I'm on both because I take Lazcluze.
Yeah.
So I started out with the osimertinib every day, and now I take Lazcluze every day, lazertinib. And it's easy to take that pill every day. I think that would be preferred. I would prefer that. But with the 5-minute injection, yeah, it's almost a tie.
Yeah. Well, and if the GLP-1s can figure out how to make those oral, we should be able to get our stuff oral someday too.
Right.
Or even bouncing the question right back at you, Jeannie. What about a longer form injection? So we've seen this with other types of therapeutics where they're given, say, once every 3 months, once every 6 months, and it's something that's like a long-acting injectable or a depot in this body. So you're getting that injection, and then it's slowly breaking apart and releasing that drug over time, but you get it maybe twice, 3-4 times a year. So I'm just curious, like, is that something that you would consider? I don't know if there's any clinical trials on that going in the cancer space. I am aware of it going on in other spaces, even for GLP-1s, for things like with HIV treatments. But it'd be interesting to know your thoughts on oncology treatment that you only have to go in for, and then your body is getting that drug at a consistent rate.
Given everything being stable, I think that a 3-month would be good. That would be preferable. With my experience with the injection right now, and this is just ongoing because it's my body, I am constantly low in albumin and constantly low in potassium. So everything has to be monitored. So that would be my question area there. When you're taking a strong drug that, it alters your whole biology. How do you monitor that? Do you require the patient to come in just for a blood draw intermittently so that you can check those vitals? Make sure there isn't liver damage occurring, or, that you're not suffering from such low potassium that it could be dangerous. That's just from my experience. That would be, I would think of it as my safety blanket would be periodic blood work in between those, during that 3 months or whatever.
Mm-hmm. Yeah, I could say as a provider, it is really hard for me to have someone come in just for blood work. We do it, we have to do it, but I feel so guilty asking someone to spend like hours of their day coming in. They get the blood draw, they wait for it to resolve, they come in, they see me, and I say, "Are you having any side effects?" And they say no, and I say, "Okay, your lab work looks good." And they're like, "Okay," and that's the visit, and so there is a tendency, I have a tendency, unless there's a clear recommendation or a clear standard, that to broaden out that length of time once we can. In the beginning, you tend to monitor things pretty closely, but I can see there's probably a risk that if something were to happen kind of out of the blue, which does happen in cancer, my impulse to not want to inconvenience the patient and want them to live their life to the fullest may lead to decreased monitoring. And it's such a hard balance. Well, thanks everyone. This has been Cracking Cancer. You can visit us at crackingcancer.org to hear more information, and we will catch you next time.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.